presence of air in the pleural space is known as pneumothorax. Pleural space or pleural cavity is a space that is present between the parietal and visceral pleura, and it contains approximately 10 to 15 ml of fluid. If we divide the pneumothorax on the basis of cause, then we have two categories. One is the spontaneously occurring pneumothorax and other traumatic pneumothorax. So, as the name indicates, spontaneous pneumothorax, they occur spontaneously, like there will be no trauma. Okay, and if we divide the spontaneous pneumothorax further, then we have two categories that are not written here. We have primary spontaneous pneumothorax and other is a secondary spontaneous pneumothorax. Primary spontaneous pneumothorax is also known as idiopathic spontaneous pneumothorax, and in this, the patient that is presenting with pneumothorax is young, tall, thin, mostly under 13 years of age men. And because in this patient, blebs are common. And in case of secondary spontaneous pneumothorax, there is an underlying lung disease. If we see traumatic, then it can be trauma to the chest wall and lung, and injury can be iatrogenic, like that can be done by biopsy and thoracic surgery. Now, if we divide into by the pathophysiology, so here we have closed, open, and tension, and this tension pneumothorax is literally a tension. It's an emergency situation. Okay, in case of closed pneumothorax, first there is a communication form, then it seals off, and it doesn't reopen again. So first there is formation of a connection, but it seals off and doesn't reopen again. So the mean pleural pressure in the pleural cavity, it remains negative, so that with time the reabsorption of air occurs and the lungs, they re-expand within days or weeks, and no dysfunction, pulmonary dysfunction occurs, and infections are uncommon. But in case of open, the communication that forms, it remains open, it doesn't seals off, so the air comes and then it goes back following the pathway. Okay, so the pressure here will be the same as the atmospheric pressure, and that's simple. So here bronchopulmonary fistula occurs. Maybe there is an abscess formation, and that abscess, it ruptures, and as a result a passage is formed. Maybe it's caused by tuberculosis or by pneumonia. The pneumonia can be caused by Staph aureus, Klebsiella, by PCP. It can also occur in CF, cystic fibrosis. But here infection is common, so empyema is visible. Next, let's move toward the tension pneumothorax. And here it's one-way valve, like the air comes but it doesn't go back, so it continuously accumulates here. As a result, the pressure here, it becomes higher than the atmospheric pressure outside. So not only this lung collapse, but also there will be mediastinal shift and the compression on the opposite side lung. So that's written here. So mediastinal displacement occur, compression on the opposite normal lung, and as a result there will be impairment of systemic venous return, and the CVS system, it compromises, and there will be signs such as tachycardia, marked tachycardia, hypotension, etc. Next, let's move towards the clinical features. So sudden onset, unilateral on the affected side, pleuritic chest pain, and dyspnea, that is breathlessness, are the most common symptoms. Yes, cough can also occur, and if it is small and on the physical examination, mostly things will look normal. But if it's larger, then on the inspection, you will see hyperinflation on the affected side, decreased chest movement on the affected side, and in case of tension pneumothorax, there will be tracheal shift. And in palpation, there will be decreased tactile vocal fremitus because the vibrations are not transferred by the air in the pleural cavity. Okay, and what about the auscultation step? Okay, and percussion? Yes, in case of percussion, there will be resonant note, and that's very important. Okay, and heart sounds are absent. So absent heart sound and resonant percussion note are very important in the diagnosis. Okay. Next, in case of tension pneumothorax, is it always necessary that there will be mediastinal shift. No, in malignant diseases or scarring, there will be no mediastinal shift. If the scarring occurs and it splits the mediastinum, then tension pneumothorax occur without shift in mediastinum. Okay, and marked features of tension pneumothorax are marked tachycardia, hypotension, cyanosis, and tracheal displacement. Okay, now let's move toward the investigation. So chest X-ray, yes. In case of chest X-ray, the pleural, visual pleural line is very visible in case of pneumothorax in chest X-ray, and no lung markings are present beyond that visual pleural line. Or chest X-ray, depth and size of pneumothorax can be seen, collapse of lung, and mediastinal shift can be seen, and it's most commonly done. Okay, ultrasound can be done in trauma or emergency situations, and CT is gold standard, but it's not routinely used. And ABGs can be done. Okay, and now let's move towards the management. So, management involves answer of 5 questions. Is it a tension pneumothorax? If yes, then just tube immediately. If no, then let's move toward the second step. Does the patient have chronic lung disease like COPD or cystic fibrosis? If yes, then just tube. And if no, now let's move toward the third step. Is the pneumothorax large, or is the patient is feeling dyspnea or breathlessness? If no, then observe the patient for 6 hours and then discharge him with a follow-up. Sorry. If yes, if the pneumothorax is large and the patient is breathless, then move towards the step 4. Check if the patient age is above 50 years, then chest tube, and if his age is low than 50 years, then needle aspiration. And next is the success of the aspiration. Like, if yes, then if the treatment is successful here, then discharge the patient with follow-ups. And if not, then just tube. Okay. So that's all about the pneumothorax. It's just a major overview. So if you like this video, click on the like button and also subscribe to the channel. Thank you so much for watching this video.